emergencies, which means that you need to know these. Sepsis, that's when his white count is really low. He is immune boosting, his immune system is depleted. I'm not going to spend time on that because we went through that a long time ago. We talked about left shift and sepsis and all that stuff. I won't spend time on it next week. You may perhaps see again on your final. But knowing, of course, that immune system could be depleted and then you need to manage that. This is important to know. DIC is difficult to treat and manage. So what happens is there's thrombosis and hemorrhaging going on at the same time for your patient. It's a state of hypercoagulation. The problem is there's too much clotting going on. The clotting mechanisms all get used up, and then he starts to bleed. That's the problem. So it's a clotting issue in the fact that there's too much platelets activity, too much clotting, all those get used up, and then he starts to bleed. So now as his nurse, you're dealing with a lot of clotting, and you're dealing with a lot of bleeding, and that's the problem. Lots of things can set that off. Decreased blood flow because of the lots and lots of clotting. So you're managing all critical body system involvements. And sometimes we don't even realize that's going on, and I speak to that because you'll cover this more when you get to OB next semester. But sometimes people, after they have a baby, the mom's body just cannot figure out how to get back to normal, and this is a complication also related to childbirth. This is a complication of cancer, and you as a nurse, again, recognize what's going on, and it's a matter of trying to manage the clotting and trying to manage the bleeding. And that's the tricky part. Sometimes the prognosis is not great because it's hard to keep that all under control. So bleeding under the skin, petechiae is never normal, dark tardy stools are never normal, we've been through that before. Hematomas, things that are showing up, you're like, oh man, wonder what they've got going on. Lots of things can cause a patient to have DIC, as you can see. Important to know is the lab values. Important to know those lab values on your screen. Why do you have a high PTT? And a high PT, what are those indicative of? The bleeding. Platelet count is low because your clotting mechanisms are used up. And therefore, because the clotting mechanisms are used up, your bleeding times are going to be high. Does that make sense to you all? You expect a low platelet count when your clotting mechanisms are used up. So there's hypercoagulation going on, and therefore your bleeding times are going to be high. Your patient has DIC, you expect low lab findings. And if you understand what those lab values are looking at, that should be pretty easy to figure out which direction they will go. Low platelets, mechanism used up, high bleeding times. So we treat it with platelets sometimes because of bleeding. We treat it with heparin to treat the thrombosis, and now you see, gosh, we got platelets going in this side and we got heparin going in this side, and they seem to be contradictory. Yes, they are. It's a hard balance to get that all back to normal. Prognosis sometimes is not good. Because the hemorrhaging and clotting all. As I said, there's symptom management. We try to keep both of those components under control. Questions about that one? Your job as a nurse is to recognize that whether it's indicating that this patient's having increased bleeding, to know what lab findings may indicate this condition, and to collaborate with your team about what's the best way to manage all of that. Okay, SIADH syndrome. We talked about that before. The cancer can affect the kidneys, or maybe it is a kidney or renal cancer, as we talked about last week a bit. A lot of water gets reabsorbed, causing the patient to have low sodium counts. Antidiuretic means, diuresis means getting rid of fluid. Anti means not getting rid of fluid, retaining fluid. So that's the issue. Too much water on board is going to dilute that sodium, and the patient's going to experience low sodium levels. That's what that SIADH means. The problem isn't necessarily the sodium piece of that is messed up. The problem is diluted because there's too much water. The low sodium is a result of excess water. The analogy that I gave you about the lemonade, yes, I put 1 pack of lemonade in. That wasn't the problem. The problem was there was too much water. That's what caused the abnormality. So because they're not diuresing, you're going to have high levels of antidiuretic hormone, low sodium levels. That's just what we just talked about. The patient's going to have too much water on board, and he's going to have low urinary output because he's retaining a lot of water. Because his cancer has affected his kidneys, whether cancer is in the kidneys or a combination thereof. And we went over all the renal stuff last week. Indications of low sodium. It's important for you to monitor those, recognize those. As you can tell, there's a lot of neuro changes that go on, that go with these symptoms. Muscle issues. Sodium less than about 110 can equate to seizure, coma, or death. So abnormal sodium levels aren't something you want to mess around with. Because a little bit of change one way or the other on sodium changes a lot for the patient. So you suspect the patient has SIADH, you expect what symptoms? I give you a sodium level of 115. What symptoms do you expect to find? Or your patient has SIADH related to his cancer. What sodium level do you expect? So there can be lots of ways that we can kind of work thinking on that. Treat the cause, increase sodium intake. Because you have too much retention of fluid, all those things that go with fluid retention. Pulmonary edema, where there's fluid building up in the lung chest cavity, suffocates the lungs. Crackles, regular vein distension, all those normal indications that you're talking about. Spinal cord compression could be an issue. I'm not going to spend time on that. We went through neuro a couple weeks ago. This is another issue. This is another issue that could be a complication. Hypercalcemia, you see high levels of calcium, especially cancers that are affecting the bone, breast, lung, things like that. Here are manifestations of hypercalcemia. Again, some GI stuff, as you can see, muscle movement issues. High calcium can cause you to have EKG changes. It certainly is. And again, you don't have to know the treatment for that, but there are different avenues that we use to try to get that calcium back down to normal. This is another important emergency. Superior vena cava syndrome. Your tumor is pressing on that patient's superior vena cava. That's the big mainstream vessel that provides blood to your heart and vital organs. The patient may present looking like this patient on that left-hand side, right-hand side when you're looking at it. Because his superior vena cava is being compressed, just picture him appearing to you as if he has a rubber band right here on his armpits. Everything above that is going to be red, congested, hot in appearance. Some of you missed the question on the autonomic dysreflexia last test. red above his injury, right? That's how you memorize all those little symptoms. If you're red like that, are you groggy? No. How are you, probably if you have high blood pressure, a red congested face? How is your affect? Pardon me?
Agitated.
You're going to be apprehensive, restless, all of that. You're not going to be groggy. When you picture somebody that's got a pale face, that's when I would equate that to somebody being lethargic, groggy. That's not how he's going to be, and that's not how your patient with autonomic dyslexia is going to be either.
So is this kind of like stating looking as autonomic dyslexia?
Yes, it is. Just picture a rubber band right on his armpits. Everything's congested, full from here on up. Because he's got a superior vein cava that's getting pressed on. And all the blood that's supposed to flow in is being obstructed. So he's going to have shortness of breath, of course, because he's got pressure on his superior vein cava. All the things, nasal stuffiness, lightheadedness, headaches, all the things that go with that full congestion up here. Questions about that? Before and after treatment? I'll go back to this one. One thing that they talk about, which isn't on this slide, but I'll write it down over there too. They call one of the symptoms Stokes collar. I don't know who Stokes is. Someday when I've done some condition, you'll read about me in your nursing book. Stokes collar means that your patient can't really specify necessarily, but said, gosh, I've been getting up in the morning and I feel like my shirt is buttoned too tight. I feel like I got the top button on my shirt too tight. That's called Stokes collar. That's not something that you assess as his nurse. That's something he reports to you, and that's what we call that. That may say, oh gosh, I wonder, I know he's got a tumor close to the superior vein cava, and he's waking up with obviously probably some swelling here, right? Especially when you lay flat. So he said, I wake up and I feel like I've got a constant state of my shirt being buttoned. That's called Stokes collar. That may be one of the first indications that you as a nurse pick up on the fact that maybe he's getting more pressure on his superior vein cava, because obviously you're getting swollen up when you're laying down, if that's how you're feeling. That's not something you assess as his nurse. That may be something he will report to you, though. Does that make sense? Do you ever feel like, I know that you have a tumor in that area, you ever feel like you wake up in the morning that you've got something restricting your neck? Yeah, actually I do. That's what it's called. And you would document that occasionally in reports. Stokes collar, that's what that means. Treatment then again is to, your priority as his nurse is to keep him breathing. Picking up on those symptoms of that, and then intervention sometimes is a stent or debulking that tumor or whatever it might be. Your priority as a nurse though is obviously keep him breathing and meanwhile so we can get that tumor altered. Questions about that syndrome? These are emergencies. You will need to know at least several of these because it's important, like I said, no matter what setting you're in, your patient's undergoing cancer treatments. Are you staying aware of the complications that could be occurring? Tumor lysis syndrome. Lysis means breaking down. That's when the electrolytes flood the bloodstream. So your tumor is getting broken down, which is good, cool. It's getting destroyed, but what happens is all those electrolytes from that tumor invade the bloodstream gets overwhelmed. And pretty soon you got abnormal labs that you're gonna have to deal with. The three specific electrolytes that seem to overwhelm the bloodstream are the phosphate, the potassium, and the uric acid. So you suspect your patient has TLS. You expect what lab findings? So look for the high phosphate number, high potassium number, high uric acid number. Phosphate goes up, calcium goes down. Most likely that'll be a number that you're gonna recognize, not necessarily that word. Again, if we give you abnormalities, we'll give you high enough or low enough or normal that you'll know that. So blood-free electrolytes will be elevated, which electrolyte will be decreased, and it's a result of the electrolytes flooding the bloodstream too rapidly in the bloodstream, you can't keep up. That's why we go over lab values and normals all along. So things like this, you can recognize what's normal, what's high, what's low, all those. Again, this is kind of looking at the previous slide. The influx, the kidneys can't keep up. Uric acid starts to build up in the kidneys, the patient experiences symptoms of gout. And that was related to increased uric acid. That I noticed it a day ago. The kidneys keep attempting to get rid of these extra electrolytes. Then we have the acute kidney injury issues that we had last week that we talked about already. So your patient comes in, has a potassium level of 6, and you're implementing all that stuff we talked about last week. Check your electrolytes for this patient.
Right now you don't.
Know what to find for electrolyte levels. Questions about the oncological emergencies? In one sentence, what goes on with DIC? Bleeding, why do you have bleeding?
Too much clotting happened.
Too much clotting. What labs do you expect to find? IPT, low platelets, correct. Symptoms that go with what's going on with tumor lysis syndrome? Okay, which three are going to be elevated?
Potassium, phosphate,
Potassium, phosphate, uric acid, which one that will be increased if your phosphorus is up?
Calcium.
It could cause kidney injury. Same direction? Yes. Good question. Yep. No. You're exactly right, because the acute kidney injury causes your strainer to not strain that stuff out. It's getting produced, built up. You're exactly right. Can't get that on that. Superior vena cava syndrome. Symptoms that go with that. Tomato head, all right. He may report what to you? Just tell him what does that mean? Not feeling that, dyspnea, all that stuff. Everything that's problematic for that patient is severe on up. It doesn't involve stuff down here. It involves dyspnea, lightheadedness, congestion, nasal stuffiness, regular vein extension, all those things that are indicating a buildup of congestion up here. Because the blood's supposed to be dumping in your superior vena cava and increasing its way through the heart. In his case, his tumors impeding his superior vena cava, causing all that stuff to back up. That's why you look like a chicken head. Right. Never had that at all analogy in my brain, now it's there. What other emergencies did I cover? Spinal cord compression, but I can go with that. We won't go over sepsis this time around. What else did I cover? SIADH. Okay, what's the problem there? Blood lab value is the issue there. And that's related to too much fluids, you lose it. Symptoms that indicate low sodium levels, could you rattle those off or recognize those if you need to? All of those. What else? Extravasation wasn't part of this section. True or false, to prevent that? Yes. How are you going to prevent that potentially? Watch your IV side. Okay, unfortunately it has occurred. What are you gonna do about that as a nurse? Take it out. Antidote, if there's one available, you put it in
Or
a tube
both
that's in your room, should be in your room. And then you just inject the area with the antidote. Sometimes more compresses, spring compress in my school does, like your bandage spring, so, yes. Notify the healthcare provider. What is your priority action in that case? Priority action, you go in and his hand looks like the one on the screen.
Stop the infusion.
Stop the IV and give the antidote. Because if it's eating the tissue, hopefully if you give an antidote soon enough, you prevent that from continuing to eat tissue away.
Can you ask for it, like, outside,
Yes, sometimes you can do that too. Yep. If it's a priority question, your job is to keep it from spreading and causing damage. Then we'll deal with the compresses, then we'll deal with notifying the healthcare provider, but act on the spot. Do we have any other emergencies that I covered? PIC, we went through that. What else? You'll have at least a couple next week because it's important for you to recognize those. All right, and what's that? I know, and it's awful. And it's awful as a care provider because you are doing that. Here's separate, here's platelets, adjust the rate, do the labs, and it's really hard to stay on top of